public figure like what we see in our clinic, patients in for one-to-one. But his job is very crucial for us. He is a backdoor, पर्दे के पीछे वाले कलाकार, वो ज़्यादा it isn't that, but it's more crucial to us. And you know that it is 85, 70, you may be knowing how Borivali was. 85, 70, when we started 85, 89, 90. Mike? Yeah. एक तो मैं आपको. So that was the time Harshad Bhai had, I think he was the only MD pathology in our area. And I was being trained into the multiple institute. I knew what is the advantage of biochemistry, the pathology, and there was only more of them are DMLTs around. Whenever the patient goes to Harshad Bhai, any alarming report, he calls you up. उस टाइम पे phone भी बहुत कम थे. Landline भी मुश्किल से था. But he used to call up. Your patient has this problem. जरा देखो इनमें कुछ है. I have rechecked my report. Then I used to go to meet him frequently. Whenever I get the chance, Harshad Bhai used to teach me many things. I used to ask him. So he has developed one-to-one relationship. Even Pratik Bhai is following the same footstep. I met him number of times. For that, and every time he gives me some new input about it. And the public relation, I mean the doctors, and how to be in touch with the doctor to inform them in time that your report, the patient's reports are so crucial that we need to look into. Or he will write or he will call up. And that is something which is great. Now Borivali, as I said, it is 85, 90, everything is evolving very fast. Our science is growing very fast. Harshad Bhai was in one laboratory. I think he has more than 100 centers. Many collection?
10 centers.
10 centers in and around Borivali. But in your leaflet, behind the letterhead, where the reports are all over Bombay, New Bombay, something.
It's a home visit.
It's a home visit. So he has developed even that home visits coming up. So it has become penetrated all through every household. You will hear the name Dr. Jariwala laboratory. That name goes to his credit. He has expanded, it is just beyond our imagination. Every household, there is a name Dr. Jariwala. So that is the credit goes to Dr. Pratik. And he has been taking, he was BMB ka secretary, Borivali Medical Brotherhood. He was the secretary for that, and he was also having the magazine, BMB has it. And there are some articles coming into that. He was writing many articles into that. I knew that he also has academic interest, so we requested him. And he without any hesitation, he said, yes, I will come and talk about we will be having topic CBC, which is, though it is appearing simple, but it's a very crucial for us in a clinical practice, how the CBC to be looked in. So we hear from his mouth that what is CBC, how important it is, what is the clinical impact of it, how to interpret it, and how to see our follow-up. First the diagnosis, after the diagnosis, what is your treatment wise and what is the prognosis and the follow-up. Everything is to be seen from that point of view. Yes, Dr. Jariwala, outside. Thank you. नहीं यहाँ थी वो हमारा प्रेजेंटेशन थी मेल खोलो ना इनका प्रेजेंटेशन वहीं पर.
So, first and foremost, my sincere apologies for being late. I'm very, very sorry. Please, thanks for having the patience.
11.
And thanks to you, Vijay sir, for inviting me to come down today.
Make it full screen. Full screen, yes. Okay. So, sorry sir. So I took a little liberty. If you see the title of the today's topic, one is the CBC, and added a word into that, which is also very big word, but without his permission, the biochemistry. So after, if the time permits, we'll ask few questions about biochemistry also. Is it okay?
Sure,
Thank you.
absolutely.
Thank you.
So, okay, so,
Yes.
and of course that was a very, very flattering introduction. I don't deserve that much of flattery, honestly. But thank you, sir. So, what we are going to discuss today is something which is very basic, okay, and as the topic says, CBC looking beyond the counts. So generally when we have a CBC report, we look at the hemoglobin, we look at the RBC count, we look at the WBC count, we look at the platelet count. So I'm not going to discuss that everybody knows in and out, and you are facing it in your day-to-day practice. What I'm going to discuss today is the other parameters which are there on the CBC report and which I believe are underutilized, and they can give a lot of information, okay, and additional information in addition to what cell counts say. So, you want to see?
Marker
lighter, नहीं, sorry, pointer.
Pointer नहीं.
Highlight. चल सुन यार देखो, मुँह करे इसको. Yeah. Okay, so this is what a regular CBC report looks like. We have the RBC count, the hemoglobin, the hematocrit. Can it be seen from here, Naisha? Not seen.
Usual report लाया हो नीचे दी copy आपको बता मैं copy.
नहीं तो चल से.
बता मैं copy.
So I'll just speak out aloud. So we have the RBC count, the hemoglobin, and the hematocrit or PCV. Then we have the MCV, MCH, MCHC, and RDW CV.
बंद करो. आगे चलिए बंद करो. आगे क्या करते? आगे. हाँ sure. Oh yes. हाँ. Can we इनके PPT में से निकाल के enlarge कर सकते हैं सर? फोटो.
सर पीछे का स्लाइड थोड़ा बड़ा है.
Okay.
So when we look at the WBC count, the platelets, we have the differential WBC count, and we have the morphology, right? Now, as I said that I am not going to talk about the cell counts per se. What I want to discuss today is the indices. We are going to look at specialized platelet parameters which are now available, and we are going to look at the absolute WBC count. Okay. So to begin with, the RBC indices. Now, this we all have learned. MCV is derived from hematocrit and it represents the cell size or the cell volume. The MCH is the amount of hemoglobin contained in each RBC, and the MCHC is the amount of hemoglobin contained in the RBCs with regards to the volume of the RBCs. Okay, so these are the three basic indices that we have learned. For interpretation, we know that MCV, anything low, okay, is microcytosis. Anything higher is macrocytosis. Same way MCH, anything low is less of hemoglobin in the RBC and it indicates towards hypochromia, whereas MCH elevated is rarely seen but it indicates hyperchromia, right? So more concentration of hemoglobin in each RBC. And then we have the MCHC, which is the hemoglobin relative to the volume of all cells. The hematocrit is a representation of all your cells, right? So that is the amount of hemoglobin relative to the cell volume, okay, that is what is indicated by MCHC. Again, MCHC is low in iron deficiency anemias and thalassemias, and it is high in certain conditions wherein the relative hemoglobin concentration per cell is high, like in hereditary spherocytosis, like in cold agglutinin disease, okay, like in polycythemia vera. Okay, so this is, these indices are good indicators, okay, to point out towards something, especially when your other parameters are normal. Like if your hemoglobin may be normal, your RBC count may be normal, but still there may be a variation in these parameters which can give a clue to some underlying disease. Okay, I'll show some examples. Okay, now this is a report of a 28-year-old diabetic. Let us ignore the counts for the moment. What we are seeing here is the MCV is 100.5. The MCH is normal, 29.9. MCHC is also borderline, 29.7. Along with that, we have RDW CV, which I will be discussing next. That is also extremely important. But what we can, looking at the indices, what we can judge or presume is that this patient is likely to have macrocytosis. So when we look at the graph, when we look at the printout, we first look at the indices, okay, and we have a basic background that what to look for before we see the slide. So when we see the slide, we know that we have to look for macrocytosis, and in this patient, the macrocytosis was seen, right? Same way, this is another case, a 68-year-old female. Here the MCV is low, 77.7, MCH is 23.8, MCHC again borderline, right? So here, because these two are low, the MCV and MCH are low, I know that I have to specially look for hyperchromia and microcytosis on the smear, okay, which has been reconfirmed on the smear. Okay, so when I'm looking at the indices, okay, I know that the smear is expected to show certain things. Now, if say MCHC would have been elevated, so normal is still 34.5, say it would have been 36 or 37. Then at that point of time, I know what to look for, as in I have to look for hyperchromic RBCs, I have to look for agglutination of RBCs. The commonest cause for an elevated MCHC is cold agglutinins. Okay, and we see them very commonly in our practice. So many times when the sample is run, we see an isolated elevated MCHC, and then we go back and incubate the sample at 37 degrees and we rerun, that MCHC becomes normal. So that is an indirect evidence that there is a presence of cold agglutinins. Okay. Now cold agglutinins, due to what? It is an autoimmune thing. Okay, it is clinically benign unless in certain cases there may be microthrombosis of the peripheral vessels, right? But here it gives me an indication that there is a presence of cold agglutinin, and these are commonest with mycoplasma pneumonia. So whenever there are mycoplasma pneumonia and we go back and we ask for the history, patient gives sometimes a history of mycoplasma pneumonia. Second thing is any type of viral infection. Any type of viral infection can lead rise to a high MCHC. Okay, so in that case also we know based on that there is presence of cold agglutinins and there is a background pathology which is going on. Okay. The next, okay, I want this discussion to be extremely informal and interactive. If any question at any point of time, please interrupt me and ask me. No problem with that, right? So then we have on every CBC report we have an RDW, right? RDW can either be CV or it can be SD. RDW means what? It means the red cell distribution width. Okay, it's a very simple thing. It is the distribution of the RBC of various sizes. Okay, so please look at this graph. Okay, this is a graph plotted for RBC. Normally for any cell population, when we plot a graph, okay, it is a bell-shaped graph or a Gaussian curve, like what we have learned earlier. Okay, you run WBC, you run RBC, or you run platelets. For everything you will have this type of graph. Okay, so what is done is, according to the size of the RBC, okay, the graph goes up, and once the size either on the x-axis it goes on increasing, the graph will start coming down. Okay, and the mean, the tallest peak is the MCV, the mean corpuscular volume, which we discussed. So this will give us an average of size of an RBC. Okay. However, what we are going to do is we are going to look at the distribution in RDW CV or SD. Okay. What is RDW-SD? RDW-SD is the lower 20% of the cells are eliminated, and this range is measured. This is the RDW CV. Now, assume that the cell population is more varied. This is a normal graph. Assume that there is a lot of microcytosis. Yes. So the graph will start from here. It will go up like this and then come down like this. Okay, so this distance will increase. Okay, so that means your elevated RDW CV will be seen on the graph. Okay, that will indicate that there is a wider variation in the cell size. Same way, if there are macrocytosis, the graph will go up like this, it will go up and come down like this. Again, this will be shifting. The RDW CV will be, SD will be wider. Okay, so that will give you an indication that again there is a varied cell population. What RDW CV is again derived from SD. Most labs report RDW CV because the range is more narrow. So in case of there is any abnormality, immediately it will cross the range and we will be able to identify better that there is a larger variation. Okay, so most labs will report RDW CV and is nothing but the standard deviation divided by the MCV into 100 expressed in percentage. Calculations of course we don't have to remember, we just should know the concept. So RDW, SD or CV, whatever is present on the report, if it is abnormal or elevated, it indicates a broad range of cell population.
But if it is not mentioned, we consider it as CV only.
Yes, RDW, if it is not mentioned, it considered as
It
CV.
is CV.
Yes, absolutely. Most labs, more than 90% of the labs will report CV. Some labs will report both, and very few labs report SD.
The clinical implications, like in thalassemia, premature
Yes.
RBC development.
Yes.
Sequestration is very
Yeah.
fast.
So, coming to that.
Okay.
So, let us look at this report. Here, if you would see, the MCV is normal. It is 83.3. We are seeing very mild hypochromia. 27 to 32 is the range. We are seeing only 25.9, and MCHC is also just borderline. Okay, so per se here there is not too much of an abnormality in the RBC population. But if we look at the RDW CV, it has gone up to 26.6. Okay, so this is something like the graph starting from here across a broad range and coming down here. That range is too wide, right? So we know that there is something more on the smear than meets the eye through indices. Okay, then we look at the smear. What did we find on smear? We found hyperchromia, microcytosis with macrocytosis. So it was a dimorphic anemia. Okay, so many times what happens, all these things will be normal. Okay, but the RDW CV will increase. Now your question, sir. Say, for example, there is an increased sequestration of RBCs. Okay, so there is a large number of atypical forms of RBCs like schistocytes, poikilocytes, all these things are there. Even with iron deficiency, there can be a lot of poikilocytes. So even in that, because of abnormal size and shape of the RBC, the RDW CV will be increased. Now, it can also be monitored to look at the response to therapy. In severely anemic cases, okay, when you are giving treatment, there is a reticulocytosis. So reticulocytosis will again, because originally the cell size is 1 and after therapy the cell size is different. Okay, again the RDW CV will be elevated. Okay, and in reticulocytosis it will also show a slight increase in MCV, which can still be normal, but it will be higher than the earlier parameter. Okay, so yeah, this is about the 4 RBC indices which I wanted to discuss. Any questions?
The hemoglobin overall is 6.5.
Hemoglobin is 6.5.
And total count of the erythrocyte is
It is
2.5.
yes, it is
And
reduced.
the return 100 grams in this hypochromia, microcytes and macrocytes.
Yes.
So it's a purely iron deficiency.
No, it is iron deficiency with B12.
B12.
It is a dimorphic anemia.
Yeah.
And I am deliberately ignoring the counts right now.
Yeah.
But we can also be seen here that there is not too much of hypochromia microcytosis because that is getting compensated by the macrocytosis.
Right.
And in addition to that, there is a penia.
Yeah.
Okay, there is erythropenia.
Yes.
Hemoglobin is low.
Mm.
Okay, so fall in RBC count is also an indicator of a B12 deficiency. Okay, cytopenia. So this was a case of dimorphic anemia. It was followed up for some time. No, sorry, this is not it. No, this is in follow-up.
Yes.
This is,
In some lecture I have heard ki when hemoglobin is low, that time only we have to look at this parameters MCV, MCH and MCS. If it is normal, we don't.
No, so that is why. So see, as I said that your parameters, main parameters are normal, maybe normal, the RBC count and hemoglobin. But still, if there is any abnormality in none of these parameters, they give a hint to what can be going on. I'll give you a very simple example of, say, sickle cell disease. Okay, so sickle cell heterozygous states, they have a hemoglobin 13, 14, 15. Okay, and they have absolutely no demonstrable abnormality on the smear except some hypochromia. But then if you have a hemoglobin of 15, why should there be a hypochromia?
Yes.
Right, so that needs to be investigated. Okay, and in those cases, you may see that the MCH is slightly low on the report. So then you have to see, okay, there is hemoglobin is 15, MCH is slightly on the lower side. So this patient can have either an impending iron deficiency or they can have some hemoglobin. Again, impending iron deficiency I am saying because whenever there is an iron deficiency, the hypochromia will always appear first. Okay, after that the microcytosis will appear. It is a gradual phenomenon, right? So that is one clue that if the indices are abnormal, in spite of your cell count is normal, that is where you need to pay more attention.
So if therapy is going on, let's say oral I am replacement is given
Yes.
intravenous nowadays, because sometimes oral iron therapy does not work because of intolerance or lack of absorption. Does this also mean that in the process when we are looking at the peripheral smear, that also indicates if the therapy is working or not?
So on peripheral smear, if you are able to see reticulocytes, that is polychromesia, okay, we can, it is again a indicator that the therapy is working. Okay, reticulocytosis should be seen. However, reticulocyte is not a part of CBC, but yes, polychromesia can definitely be identified on CBC, and we can presume that there is reticulocytosis.
So before hemoglobin rises, we can see the changes in the indices?
Of course. No, not before hemoglobin rises.
It will be only
Okay, it
after.
will be a constant process. Okay, but when you are talking about hemoglobinization of the RBC like MCH is getting corrected, yes, that will happen even before a demonstrable rise of hemoglobin.
So that can be a prognostic thing for us, no? If the
Yes,
medicine
but
is
that,
working.
you know, that is
Difference is very small.
that difference is very small and is subjective. How to interpret? Every person will interpret in a different manner. So, any questions so far?
So in this indices, how do we sometimes thalassemia major, minor?
Ah.
What are the differences coming down?
Right. So that is what the next slide is about.
Okay.
Okay. So then we have whenever the hemoglobin on the MCV is low, okay, the labs will report certain calculated parameters, okay, on the in the report. Like the first one, which is Mentzer's index. Okay. This index is a very simple calculation. It is there on the report. We don't have to calculate. It is the MCV divided by the RBC count.
Right.
Okay. Whenever this value is less than 13, okay, it is suggestive of a beta thalassemia trait.
Okay.
Okay. And if not, it could also be some other hemoglobinopathy. If it is more than 13, it goes more in favor of iron deficiency anemia. Same way, Sehgal's index has been invented by Dr. Kunal Sehgal, a good friend of mine. He's a hematopathologist. So what he said is that you square the MCV. So MCV square and then you divide by the RBC. That gives you a better sensitivity and a positive predictive value. So that figure, if 972 or less, suggests beta thalassemia trait. More than 972 suggests iron deficiency anemia. Okay. Now traditionally, what has been said is that in thalassemia, there will be hyperchromia microcytosis, but the cell population is uniform, which means the RDW CV should be normal. Okay. However, in our population, we see a lot of iron deficiency anemia, and many times both are there together.
Yes.
Okay. So I'll give further examples in my next slides. So in such cases, we need to first give the hematinics, and then screen again for the hemoglobin and see if the level is risen or not. And if not, then you have to go back and screen for thalassemia. Okay. There is one more very beautiful formula, okay, which is not there on the reports. Okay, but this is almost a short thing that if the indices fall in this formula, okay, the formula is hemoglobin into 5 plus RBC count plus 3.14. If this is greater than MCV, okay, there is a very high likelihood of thalassemia. So, thalassemia or some other hemoglobinopathy, of course, thalassemia is the most common. Again, a thalassemia trait. Okay. Now, when we talk about a thalassemia major, okay, we see a hemoglobin which is almost always less than 9. We see a lot of normoblasts and polychromesia because it is a actively, it's an active hemolytic anemia. So there are a lot of normoblasts on the smear. There is a lot of polychromesia, a lot of reticulocytosis. And at the same time, the cells which are present, they have very severe hypochromia and microcytosis. So that picture, itself, looking at it, we get a clue that okay, this patient could be a thal major. From indices point of view, there is again MCV, MCH are usually extremely low. The RDW CV again is greatly elevated because of multiple cell population. So let us look at this slide. Okay, this is a 63-year-old male. Hemoglobin 10.7, MCV is 64.6, MCH is 20, okay, RDW CV is 16.2, okay, not greatly elevated. Right, here the Mentzer's index is 12, so it is less than 13,
Yes.
and the Sehgal index is less than 972, it is 775. Okay, so we have two formulas which state that this falls in the BTT range. Both are low, and there is likely to be a BTT. And this patient will definitely, investigated further, okay, will turn out to be beta thalassemia trait. Okay. On smear, hyperchromia, microcytosis were there, poikilocytosis were also seen, and mild polychromasia, okay, indicating a reticulocytosis also was there. Okay, so this is very likely to be a beta thalassemia minor. In contrast to that, we have one more case, okay, wherein the indices are more or less similar, MCV 69, MCHC is 20.7. Okay. However, RDW not greatly elevated in this particular, it is usually elevated. But the indices, the Sehgal index and the Mentzer index, Mentzer is more than 13 and Sehgal is more than 972. So this goes in favor of an iron deficiency anemia. Okay, now it is still possible it is iron deficiency with beta thalassemia, but here the primary correction required is for iron deficiency. After that, if it does not correct, then you screen for thalassemia. Okay, any questions so far?
Iron is already high, we cannot supply that.
No, so in, what happens is that, many a times when the hemoglobin is low, okay, the patient is given oral iron, okay, assuming that it is an iron deficiency anemia. But like in this case, here, because the indexes are indicating towards the thalassemia, here there is no need to give an iron supplementation. Here the patient should be screened first for thalassemia. If negative, then give iron. In contrast to this, the next one here, iron therapy is required first. Okay, and then you screen for thalassemia. Now your question, in thalassemia iron is more. Okay, that is in thalassemia major. Okay, because of constant hemolysis. Okay, the iron is accumulated in the body. Okay, but it does not, external iron supplementation also does not help. So that is where the iron is elevated and you don't have to give further in thalassemia. Yeah, it requires chelation, but chelation is not required unless the patient is on therapy on multiple transfusions. If the patient is given multiple transfusions, there is an iron overload, and because of that, a chelation therapy is required.
Can we talk more about hemoglobin A2, A1, A2, like how is the level of that? And
Okay, so normally the highest amount of hemoglobin in our body is hemoglobin A, right? A is somewhere in the range of 95 to 98%. Okay. Then comes hemoglobin A2. Hemoglobin A2 will be somewhere from 1.5 to 3.5. A2 3.5 to 3.8 is taken as borderline. Anything more than A2 3.8 is classified as a thalassemia. Okay. Fetal hemoglobin is negligible, 0.2, 0.5. Okay. So whenever there is a hemoglobinopathy, okay, I am talking about hemoglobinopathy, not thalassemia. Hemoglobinopathy, the adult goes down, okay, and the abnormal hemoglobin, it could be sickle cell, it could be HBD, it could be C, okay, any other type of hemoglobin, the adult will be less and the other type of hemoglobin will be high. Okay, so that can be seen on hemoglobin electrophoresis or HPLC analysis. Whereas in thalassemia, the adult is very much there, the A2 is elevated. Okay, so that is what we call a thal minor. In thal minor also fetal is not increased. Okay, fetal will usually be increased when there is a homozygous state like a homozygous sickle or a beta thalassemia major. That is the time fetal will increase. Otherwise, fetal is normal.
was the therapeutically whether to give iron or not? It depends on that.
So therapeutically, giving iron or not will depend on this.
Okay.
Okay, because those things, irrespective of iron, will not change. That is a genetic condition. It is going to stay permanently like that. So iron to be given or not will depend on this. Okay, and if RDW CV is elevated and indexes don't fall, then definitely yes, iron has to be given. Okay. Now next I am going to take up the platelet parameters, and this is so because in last several years we have seen a lot of new platelet parameters coming in and which are extremely useful. Okay, the first one is an MPV, the mean platelet volume. It is similar to your MCV for RBCs, same way MPV is for platelets. The reference range is from 6.5 to 12. Okay, then we have the PLCC. PLCC is the platelet large cell count or the large platelet count. And now we have technologies and methods wherein the large platelet count is measured separately. Okay, large platelet count, why we need is that large platelets are the immature platelets, so the new platelets, young platelets, when they are released from the marrow, they are larger in size, and as they mature in the circulation, they become smaller. So when we have a large platelet count, we come to know that there is a response from the marrow, right? The same thing is the PLCR. PLCR is nothing but your platelet count divided by the large platelet count. So some labs will report PLCR, some report large platelet count, whatever is available to them according to the technology they are using. Okay, we also have IPF, which is very popular. IPF also has the same role. The only difference is in IPF, we are measuring the RNA inside the platelet. So when the platelets are more mature, the RNA content of the platelet is higher. As they mature, the RNA becomes less. Okay, so here it is the size of the platelets. Here is the RNA content of the platelet. The utility of all these parameters is the same. Okay, the utility is that yes, when there is a thrombocytopenia and there is a release from the marrow, we are looking for how good the patient is responding. That is where these parameters will be useful.
So in which cases LPC, large platelet counts are high?
So large platelet counts are normally not high. Okay, they will be high only when there is a release from the marrow. Okay, so this next slide will explain. Okay, so this is a recent case, somewhere in September or someplace, which was a 27 or 28-year-old male who was admitted on day 6 with a low platelet. He was dengue positive, NS1 antigen positive. Platelet count on day 6 had fallen drastically, very unusual because it takes a little longer to fall. Okay, it was 56,000 on day 1 with minimal large platelets, IPF of 2.3, and the mean platelet volume was 7.8. Day 3 they still dropped down, again no response is visible in terms of large platelets or IPF. Okay, the patient's count is going down, but there is no response from the marrow. Then on day 4 the count was 29,000, still going down. However, there was some release from the marrow which was observed. Even the IPF went slightly high, but this is not so significant, but slightly high, yes. So there was a beginning of response from the marrow. Day 5 the count still dropped. Okay, but again the large platelet count in IPF did increase tremendously. So this is the time when we can confidently say कि आप 2 दिन बाद कराओ आपका बढ़ जाएगा. Okay, so day 7 look at this, 88,000 and 28,000. Okay, so here this is very useful because when the count is 26,000, 29,000, the hospital will also panic and they would ask them to arrange for a platelet transfusion. Okay, but here we get a lot of confidence in telling that just hold on, nothing is going to happen because the marrow has now started responding. Okay, so this is the only utility of the platelet parameters and the indices, that when there is thrombocytopenia, release is taking place from the marrow. If you want to look at that, if the patient is responding, not responding, marrow is responding, this is the time when these platelet parameters are useful. Now your question with regards to the large platelet, in which conditions? So pathologically there are no conditions. Okay, there is one very rare condition called a giant thrombocytopenia, okay, which is actually debatable if it is pathological or not. Okay, and secondly, people from northeast, okay, Bengal and Assam itself, they have a tendency to have slightly higher platelets compared to those living in the western part of the country. Okay, so and that too also the average size is 15 to 16 femtoliters for platelets. So not very drastically high. Okay, but that is a genetic variation or regional variation that is being observed. In northeast people, they have a slightly higher platelet size. Apart from that, this is the only utility.
Any significance in cases of cancers?
So cancers again, platelet, if there is thrombocytopenia and they give the graftal injection or something, so that is the time when there is a lot of release from the marrow. So at that point of time you can see large platelets. Okay, that is just again you are monitoring the response to therapy. That's nothing else.
MPV is also size of?
MPV is the volume, yes, it's the size. So whatever is available you can utilize. But MPV, what happens is that when we, because it is related to cell volume, okay, and by the time our sample is collected from the hospital and we get it, okay, there is cell swelling which happens. Okay, so we don't rely that much on MPV unless the sample is collected in the lab itself and transported within 2 or 3 hours. Okay, the same issue can arise with large platelets also. There can be an increase in the cell volume, but it is not that great of a number that will increase when you compare it to the MPV. So still large platelets will be a better option. And in such instances, if the patient is hospitalized, it is going to take time or the sample is to travel a lot, the best thing will be to do an IPF. IPF will actually measure the RNA content, it will not take the cell size into consideration.
This is part of the regular CBC or it has to be requested?
No, so this is a part of the regular CBC. I mean, see, it depends from lab to lab. Okay, what we do is if the platelet count is below 1 lakh, okay, we are doing IPF and reporting the large platelet count by default. Okay, there may be some labs which you may have to request separately.
Because it seems that compared to the total count of platelet, this seems to be a more reliable indicator of the prognosis of the
It
disease.
absolutely is. It absolutely is. Okay, and that is why this holds a lot of value. Okay, especially in the area where we are residing with a lot of dengue going on every year. Okay, so see here, as I demonstrated, 29,000. Okay, there is DIC going on, platelets are low. The DIC is still continuing, but the body is fighting back. Okay, so this is a very good prognostic sign.
So we are mentioning IPF also.
IPF also. Yes, yes.
So large platelet should be monitored. If it's increasing,
Large platelet should be monitored. When it comes to large platelet, now don't go by the range. Okay, this range is there for
Go by the trend.
you have to look at the trend, not the range. Even for IPF, all these platelet parameters, look at the trend. That needs serial examinations.
Okay.
Sir, how frequently, see, it's very empirical. If the platelet is not so low today, I don't know if tomorrow it will go down because we don't know what is the kind of immune response. Sometimes even with low fever, the immune response is very high. We only
Yes.
know with either hypotension or restlessness in the neck.
Yes.
So is there any sort of way in which we can decide this should be done daily, alternately?
So there is no guideline with regards to that. It has to be on clinical judgment only. There are no guidelines, and I cannot say to you repeat every 24 hours or repeat every 48 hours. It depends on the person treating the patient.
So in pathology there is no such.
No. There is no guideline as such.
Can we
Because
ask for-
every case is different.
Can we ask for only large platelet count then in that case? The platelet count and the large platelet
So
count?
you can ask for the regular platelet count only. Okay, if it is less than 1 lakh, you will get the large platelet.
Okay.
You will get by default. Or if you just want to look at the large platelets, just ask for IPF. That will be better. Because IPF will not have the large platelet count.
Because then it occurs to me that let's say in the morning the platelet count was 1,50,000.
Yes.
Last platelet count was not done. Patient worsened in the afternoon, and in the evening when we do the platelet count, it has dropped significantly,
Right.
below 1 lakh.
Correct.
So probably in the morning, if the last platelet count was done, it would have already indicated that it has gone down, and then now the total platelet count will go down. Does that make sense?
I didn't understand, sorry.
Rapid deterioration of patient. Morning patient has 1,50,000 platelets. By
Okay.
afternoon, you get a call that the patient is deteriorating.
Okay.
Obviously, you admit the patient in the room. But then when you repeat the platelet count, it has dropped significantly. Meaning that in the morning, if the large platelet count was done along with the total platelet count, and if it would have come low, that would have been an indicator. Meaning normal platelets, but low large.
Yes, so if there is no response, so large platelet count are not there on the smear, what you are saying, right? In the morning count. So that itself indicates that there is no marrow response.
Okay.
Right? So then that is likely to go down. It is likely to go down. That is the question, right?
I think, yeah, I'm also trying to reframe it
Yes.
in the clinical scenario.
Marrow response is this PLC.
But then every time it is
Exactly.
sure that the both things have to come down simultaneously, or the platelet count will go down and the large platelet count will go up.
No. So it is not every time it will happen. Your platelet count going down is an indicator of your DIC.
Yes.
It indicates a separate thing.
Yes.
Okay, large platelet count is coming from the marrow. Okay, so they are actually contradictory to each other.
Actually.
Right. So we are, if there is no response, there is no large platelet count, but the platelet counts are still dropping. That means that the patient is still in DIC and it is overwhelming DIC. The counts are likely to drop further.
But the increase in large platelet count is always favorable.
It is always favorable. Yes. Always favorable. Okay. I get a lot of requests for manual platelet counts. Okay. I want to know why do you request for So I'll tell you what typically happens is when the platelet count is low. Okay, we definitely get a call back and they say, okay, I want a manual platelet count for this patient. Okay, now I just want to explain the concept behind manual platelet count. Okay, it is very important, and we get a lot of requests where in a low platelet count, doing a manual platelet count is not required. It is futile. Okay, I'll explain why. Okay, so this is the graph we earlier saw. Right? Now this is a representation of what goes in the cell counter when we run the sample. Okay, so this is the RBC graph, right, which is read electronically, and at the same time this particular part here, based on the size, is counted as platelets. Okay, so if we zoom this now, there will be a small Gaussian curve over here, and then this RBC graph will start. So that part of the graph in the same, that area of the graph in the same graph is the platelet count, which is considered or read by the machine. Okay, the cell count. Now, what is machine considering is the size, right? Why it is considering? Because the size of the platelets is lesser, it is considering that part as a platelet. Now what happens is, whenever there is a severe microcytosis, meaning micro RBCs, okay, so this graph will overlap with this graph over here, and the machine cannot distinguish what is platelet and what is RBC. So it will count the micro RBCs also as platelets, okay, and the platelet counts will be falsely high. Okay, the RBCs are getting counted in the platelets, and it is adding to the platelet count, and platelets will be falsely elevated. Okay, so we should have a high platelet count on the report if that is the case. So manual platelet count should be requested when the platelets are high with severe microcytosis. Okay, what we get is exactly the opposite. Right. So when you have elevated platelet count with severe microcytosis, that is the time you should ask for a manual platelet count, not when the counts are low. Okay, this is very, because every request I get is for a low platelet. You recheck manually. Doesn't help.
Yes.
Okay, that is not to be done.
Clustering is not
So clustering, no, it is independent. If you have a low platelet count, when we see the smear, we are able to see the clusters on the smear. We will correct it, or we will ask for a repeat sample. So, see, the point is, if the counts are low, a smear examination has to be done. And on smear, we should be able to identify those platelet clumps. Otherwise, what is the point? Right, so maybe if smears are not being looked at and you are suspecting कि इसका platelet count low है लेकिन normal होना चाहिए था, तो maybe yes, you can tell them to relook. Okay, but certainly a manual platelet count will not help. Why? Because the clustering which is there in the sample, okay, is going to reflect in the counts also. So clustering what happens? It is clumping, right? Clumping of the platelets. Clumps side पे हो जाते हैं, बचे हुए जो free platelets है वो ही count होते हैं. तो clump sample होगा, उसमें भी आप manual करोगे, तो आपको कम ही मिलने वाला है. Have you ever come across that the platelet count is low and manually you have done it and it has been in lakhs or thousands or normal?
It cannot.
It cannot happen. Okay, so when the count is low, ask the lab to relook at the smear and look for platelet clumps on smear rather than asking for a manual platelet count. And see, because labs also know that these things are possibilities, there are chances of error over here. So whenever the counts are low, the more attention is given to that sample, and all these things are ruled out before reporting. So we take care of it internally. If required, we run the sample by another technology. We run the sample. I'll come to that also, other methodologies which are available. Okay, so there are multiple options available to us wherein we can verify the platelet count before reporting. And every low platelet is given a lot of attention to, because it could be anything. It could be leukemia, it could be malaria, it could be dengue, it can be anything. Okay, so as I mentioned, microcytosis interferes and gives a false elevation of platelets. Now, however, these things are now very well taken care of, okay, by the technologies which are available these days. Okay, like I mentioned, the newer technologies, there is an optical platelet technology wherein the platelets are, imaging based reading of the platelets, that actually the platelets, they pass through the channels and the instrument actually sees what platelets are going on, okay, electronically. Okay, so that is an optical platelet. There are fluorescent platelets like the same in IPF, what we do. Okay, those fluorescent channels are present. And hybrid platelets are also available, wherein the original methodology of impedance over there and optical are combined, and using AI, the hybrid platelets are reported. Okay, so all these errors which are happening or which used to happen, okay, now they have greatly reduced. Okay, and when you have a platelet count which is normal in the absence of microcytosis and a platelet count which is low in the absence of microcytosis, in either of the cases you can trust that the platelets are low or normal, whatever the case.
So a lot of attention is going on around the platelets, the clinically,
Absolutely.
even prognosis and diagnosis.
These parameters available over the last 8 or 10 years, they have actually drastically changed the way hospitals are now looking at, and even on OPD basis, I am sure you must have experienced that.
Yes.
So, unnecessary, the platelets are low, but if you feel that the patient is comfortable, okay, and you see a large platelet count, you can just reassure the patient, no need to hospitalize. Okay. Now, again, when we look at the CBC reports, okay, what has been traditionally taught to us, or what I have also learned, is that you look at the differential WBC count.
Yes.
Okay, so what we do is we look at the percentage. Okay, but rarely we pay attention to the absolute count which is present along with the percentage. Okay, I'll just highlight in this case here the total WBC count is 17,750. Okay, we have 83% neutrophils. Okay, and the absolute count is 14,733, which is actually elevated.
Yes.
Right? The normal for neutrophils is 2,000 to 7,000, the absolute range is. Okay. Now, if we look at the next slide, okay, here what we are seeing is the WBC, the neutrophils are 53%, which are normal. Okay. The lymphocytes are 42%, which are slightly borderline. 25 to 40 is the range. Okay. However, how, if it is only comes to differential, how would we interpret this differential count? Okay, I would take it as normal. Okay. However, if I am looking at the absolute count over here, 1,562. Okay, which is normal for lymphocyte, but this count 1,972 is less for it. So this is not actually lymphocytosis, this is neutropenia. Okay, this again the total count is low. Okay, so when I'm in such scenarios, when I'm looking at the absolute count, okay, this turned out to be typhoid or positive very strongly, both IgG and IgM. Okay, this is couple of days back. Okay, so here I was able to make out that there is neutropenia. Okay, proportional lymphocytosis, if at the most you want to call it. Counts were low, but this case turned out to be that of typhoid. Now assume that this count would have been normal.
Yes.
Okay, with this stage, I would have got a normal neutrophil count. I would have got a normal lymphocyte count also, absolute count. Okay, so in those cases, I would not have been able to differentiate. But here, because there is less demonstrable neutropenia, okay, I was able to check if this patient has something else or not. Okay, so there can be a lot of ifs and buts in this, but this is something which I wanted to bring out.
But why it happened like that?
Sorry?
Why the neutrophil count was normal and absolute neutrophil count?
So the neutrophil count we are.
What is the difference?
Yeah.
How does it
Yes.
calculate?
So neutrophil count, what we look on percentage, it is out of 100. We have a finite set of 100 cells in which we are counting the neutrophils, right? So here it was 53%. Okay, according to the differential percentage wise, we take it as normal. Okay, but when you have a variable cell count, your WBC count is different. Okay, then you look at the absolute neutrophil count. Okay, so in that case, it was low. So absolute neutrophil count will be different. It will be 53% of 3720 over here.
Okay.
Okay, so though it is 53%, percentage wise it is normal, but looking at the absolute value, it is abnormal, it is less. And that is the reason we need to look at the absolute counts also when looking at the
So
values.
always it has to be cross-checked between the neutrophil count and the absolute count.
It should be done, yes. Not neutrophil count and absolute, just compare the absolute count with the normal reference range.
So is it more that in cases of eosinophil we see a higher response in absolute eosinophil count rather than the eosinophil?
So eosinophil, if your count is normal, say for example, okay, and you say that okay there are 5% eosinophils, you look at the absolute count also. If your absolute count says that it is normal, okay, hold on. But if your absolute count says your total count may be 15,000 and eosinophil count may be only 4%, but then again the absolute eosinophil count 4% of 50,000 if the absolute count is going to be high. Okay, so in that case you have to take it as eosinophilia and investigate in that way.
And start the treatment accordingly.
Yes, if of course symptomatic ho to. Because many a times in our city eosinophil high count is seen, very common, right? So then of course symptomatically if he is fitting, then you take it as eosinophilia.
So essentially percentage is only just a factor for
It is a factor. Yes, it is. We count 100 cells and we see how much percentage is what. Okay, but then ultimately the absolute count which is there is also equally important. I'm not saying that is not important, but it's also equally important, and we don't look at it.
So eosinophil sometimes remains 0% even in the acute fever.
Yes.
Any indication do you find? Clinically of any
So
importance?
why we have seen eosinophils like you said in zero in absolute in acute fevers, and
Yes.
we've seen quite a few in typhoid cases also.
Right, that's what it is.
Okay.
It is
So, but
indicated.
then we regularly, commonly also see eosinophil count 0 also.
Zero.
So that has to be correlated.
So whenever there is any fever and 0 count, that means we should keep it in mind.
We should
It
keep
can
in
turn
mind.
into
Absolutely, it
Yes.
can be either typhoid or it
watch,
could be
watch for
Because
it.
first line of defense is both neutrophils and eosinophils.
Yes,
So
yes,
it sometimes can
absolutely.
Yes.
The significance of monocyte and basophil.
Monocyte.
So monocytosis are
Not
again.
very significant, but then also.
So monocyte is again a macrophage
Yes.
cell.
Yeah.
Okay, so it is elevated in your infectious, any type of infection, including viral infections. There is some macrocytosis, monocytosis which is seen.
Okay.
Okay. Basophils again. Basophil is a reactionary cell like it's a granulocyte like eosinophil.
Yes.
So there are specific conditions like CML is very common where we know that basophil counts are increased. Basophil counts can be increased in any type of mast cell disorders. Okay, they can be increased as a reactionary basophilia also. When you have a leukoerythroblastic reaction secondary to infection, that is also the time when basophils can be elevated. So not many conditions.
Sir, any reference with CBC to non-hematological oncology disorders? Any sort of, if we can
Okay, so you are talking about malignancies in general.
in
Yeah.
general, but not hematological malignancy.
Non-hematological malignancy. So this typically happens, see, when you are looking at malignancies, on cell morphology we don't see much. Okay, at the most what we will see is that there is some suppression of counts. There is anemia, okay, and maybe associated iron deficiency leading to some hypomicro kind of a picture. Apart from that, we don't see any other morphology on the CBC. In contrast to that,
Please go.
in contrast to that, if the patient is on chemotherapy, then we see a lot of changes. Okay, there is a monocytosis, there is vacuolation of neutrophils and monocytes. Okay, or at the in chemo there can be a gross agranulocytopenia also. So that also can be seen. And once you give a injection, a granulocyte macrophage CSF, so when you give that injection, you see a lot of immature cells. Okay, in non-hematological malignancies ranging up to blast cell also, because there is so much of sudden outburst from the marrow, you have everything increased. Okay, so that all depends on what is given or what is not being given.
So actually what I was asking is exactly the opposite to what the doctor was saying. Okay, what are the red flags that we have to be sure that are dekhayun blood CBC na report ma, that means there is something wrong. So what are those 2-3 things that we should keep it in mind?
So
Including
there-
hemoglobin, WBC
हाँ,
also.
so when you're looking at anemia, you have an healthy male. Okay. Say for example, hemoglobin is low. Okay. There can be two types. Either it can be a normochromic normocytic anemia, which can be because of acute blood loss. Okay, or a chronic, which will lead to an iron deficiency anemia. Okay, hypomicrovoid. So in those cases, okay, a stool examination is mandatory to look for, if there is any occult gut in the stool or not. Okay. At the same time, if the general condition of the patient is, for patient says, I don't have anything, I am healthy, I am eating everything, but still I am feeling very weak, I am losing weight. So in those cases, then we have to look for specific markers for cancer, be it in any form. You can get a CT done, you can get a PET done if you're not finding anything, you can do blood markers. The blood markers are not always reliable in 70-80% of the state. Yeah. Okay. So as screening tools, only PSA and CA125 are the only two screening blood markers which can be utilized. Apart from that, everything else is for prognostication. Okay. So, I mean, it will have to be judged completely looking at all the parameters. Now, if you're looking at a hepatoma, definitely some derangement of your LFT will be there. Okay. So it will become again organ specific on where you want to look at.
In thrombocytosis, till what platelet count it is considered as normal? Though the range is given till 4.5, 5 lakh, but I've seen doctors not treating till 6 lakh, 7 lakh, even 8 lakhs.
See, 6 lakhs is what we take as normal internally. Anything more than 6 lakhs, we say it is increased, elevated. Okay, but however, treatment is not indicated because you have to establish that this thrombocytosis is due to a malignancy. Okay, it's a platelet leukemia. So in that case, a bone marrow has to be done first, and then if at all it is proven to be a malignancy, then you have to treat those thrombocytosis. There are cases where elevated thrombocytosis or essential thrombocytosis like picture is there, okay, wherein the patient does not have a tendency for clotting. So in those cases, they are just left alone, don't do anything.
How about the lymphocyte neutrophil ratio? How do we?
So neutrophil lymphocyte ratios are becoming very popular during COVID.
Right.
Okay, and it per se does not have any relevance as on date.
Okay.
Okay, it is just that neutrophils, there is neutropenia or there is a lymphocytosis, and elevated lymphocytosis, it goes in favor of viral, and elevated neutrophils goes more in favor of a bacterial infection, but that does not hold true. That was just an observation. In fact, monocytosis also reported by many people at that point of time. But then it is ultimately the spectrum of the same illness is what we are looking on a day-to-day basis.
So, as far as those routine illnesses are concerned, what we consider NLR between 1 to 3, so it's more of an infective type, good for prognosis. Does it hold any true, or it was only for COVID purpose?
No, so it was again. So it was an observation which was seen during COVID. Okay, then because there was only COVID, it was documented. Okay, so I don't think there is any significance.
So there are some labs which give an atherosclerotic index also
on
CBC.
On CBC.
That is not
lipid profile.
Yeah, lipid profile. Yeah,
Atherogenic
It
index.
is if you know Shruti laboratory Jhupar so they give that. I'll show you the
CBC per.
CBC.
Please, I am not aware about this. Just show me the
Can I show you?
you can forward it to me. Or circle it.
Yeah.
Results for high platelets.
So most of the times thrombocytosis is reactionary in response to a particular illness. Okay, like when you have even viral infection. Okay, initially there is a reactionary neutrophilia. Okay, so initially the neutrophil count goes up. After that it falls. Okay, same way to any insult to the body. Okay, there can be a reactionary thrombocytosis. There can be a reactionary neutrophilia. Okay, but it is transient and temporary.
Chronic illnesses.
Chronic illnesses generally don't lead to thrombocytosis. It is acute.
So how these the normally what we see we give the CBC and ESR and different cell related. How the ESR to be again correlated with that chronic inflammation with thrombocytopenia or thrombocytosis everything. They give a panel of the investigations, which is most important. We should refer it to.
So
Investigations.
correlation with ESR.
Yeah. The chronic inflammation, is it just reflected into the cell count also? Is that?
So chronic chronic
Inflammation.
inflammation will lead to anemia of chronic diseases.
Okay.
Okay. So that is the only thing it will lead to, because there are those proteins which are there. Okay, the ESR count will be
Go.
elevated.
Yes.
Okay. Apart from that, direct correlation with the cell count is
So it's a part of scrutiny or routine.
It's a part of scrutiny. It's an independent thing.
Yes.
In old age, they say the ESR is age divided by 2 is normal. Is it true? For example, the 90
It is, sir, no longer true, but it is roughly true.
Yeah, roughly true.
So again, an observation.
To the ESR in old age,
Yeah.
if it is not very high.
Ah.
Right?
And so see, ESR, the thing is, at some places ESR is extremely useful. Okay, and some places it is extremely useless and confusing.
Yes.
Okay, like in acute conditions, if you are doing an ESR, it is not going to be useful. What are we
CRP
going to
is
achieve?
better.
CRP is better, correct. Whereas in chronic conditions or the underlying illness, if you have everything normal but your ESR is elevated,
Yes.
मतलब कुछ गड़बड़ पक्का है.
That's what my
Okay.
point was. That
Yeah.
was it.
Yeah.
So you know, I have seen cases where on marrow, with isolated ESR elevation, everything else normal on marrow, the patient has turned out to be leukemic.
Oh.
Okay, to that extent. So I am a very strong proponent of ESR when it comes to a chronic and long-standing illness.
Because what is very valid point, because of the rising number of malignancies.
Yeah.
If patient is normal, initially malignancy is known to not have symptoms.
Not have symptoms. Isolated ESR elevation will
Ah,
be.
yes, this makes more sense now
Yeah.
to add into everything.
Absolutely.
So again, what ESR level we have to be?
So the ranges for men and women are different, barabar se, but you know, any ESR above 40, 50, okay, should at least be looked upon.
Young people.
Young people, all age groups,
Yeah.
all age groups.
And elderly might usually higher side.
Elderly might is there usually in the higher side, but then can you ignore that high value? Is the question. Elderly are more likely to have a problem.
Yes.
So bone marrow is the best thing to
No, that's what it is.
Depending on what the presentation is. Okay, if nothing, then marrow has to be looked at. Then marrow has to be looked at. But that marrow will come after your PET scan.
Okay.
After you investigated everything, not found anything, then finally you go for marrow. Why the ESR is elevated?
So can we have some talk about the hormonal levels, diurnal variation? Because one of the things which you have we discussed about is progesterone. I mean
Prolactin.
Prolactin. Sorry.
Prolactin is a nuisance for us.
Very
it's a headache for us.
For us also.
So what happens is, you know, most of these hormones, they have a pulsatile secretion.
Yes.
Okay. Especially prolactin. Okay. Prolactin, typically what we have observed is that it is greatly elevated in the morning hours. Okay. So many times we have come across with young females having prolactin of 100, 120, 130. Okay, we tell them to come back in the afternoon or the evening, 12, 15,
So much.
that much. Okay. Probably it's just bad luck, maybe because the sample was collected when the pulse had come. Okay, we don't know, but typically we have seen that elevations in the morning. Prolactin. The same thing is applicable for TSH also. Okay, TSH also, that is the reason we put say 4.5 to 9 is a borderline value, and you don't treat the patient, you repeat the TSH. So morning we have seen several times TSH is 7, 8, 10, then we call them for a repeat. Okay, it becomes 3.5 in the afternoon.
Okay.
This is the ideal time for TSS.
So ideally it should be afternoon. Ideally it should be afternoon, but see,
Anytime but
it is not practically possible,
Yeah.
because with this battery of investigation, usually there is a fasting sugar, there is a lipid profile.
Yes.
Okay, so we do the test, okay, and if there is a scenario like this, okay, then we call them for a repeat sample. Most of the times it is fine, but this out of 10, 1 or 2 cases will have this problem.
So is it almost all the hormone battery, whenever we request, it should be done around 4 or 5 o'clock?
Except
You
for
mean-
cortisol.
So cortisol morning 8 a.m. 8 a.m. is required. Apart from that, it is ideal that you ask for it in the hour.
Okay.
We come to know the baseline levels.
I think so. Metabolism does that for prolactin triple assay test.
So it's a
triple
pooled,
test.
it's a pooled prolactin. So that is precisely the reason why it is done.
So how is that different from us?
So what is done is the prolactin in pooled prolactin, the sample is collected over 1 hour and 3 samples are collected. So now see, we prolactin has a half-life of about 25 to 30 minutes. Okay. So say assume that there was a spike and the level was 100. In 30 minutes, it will become 50. In the next 30 minutes, it will become 25. Okay. So pooled prolactin, this is the principle that you collect the sample at different times so that you get an average value and you eliminate this. But what happens is the patient has to be poked 3 times. Okay, so instead what we prefer is that we do it once. If it is abnormal, then we call it them at another time. In addition to that, when the patient is taking those anti-emetic and anti-nausea, domperidone, okay, that also is known to increase the prolactin. So we ask the patient if you are taking any
You have to
anti-emetic.
actually write in the requisition form only that patient is on.
So that will lead to a falsely elevated prolactin. So that is the most common reason actually.
Very often we have seen even the endocrinologist doesn't request so frequently that evening it should be done. And the patient come with the treatment also that false elevated they have been treating.
It does.
It do happen.
It does. But thankfully in our area with the eminent endocrinologists which are there,
Yes.
they all ask for a monomeric prolactin along with it.
Yes.
Okay, and I have an interaction with them, so they take care to mention the history or tell the patient.
So about the any markers that if you can talk about, like EGFR, you have written an article also in BME.
Long back,
Yes, long back. Really useful. Really useful.
remembers everything.
Yeah.
When was that?
Because
So-
it was very much in trend when
Yeah.
initially you started it, and I used to ask for those who have chronic hypertension and the diabetes along with that. Instead of doing microalbuminuria, we asked for the EGFR.
Yeah.
And many laboratories were not doing it. Though it is a derived equation and then you can derive it.
It's a very simple
Very
calculation.
simple.
Very
Very
simple
simple.
calculation. And the calculation not simple but it's available easily.
Available
Yeah.
easily.
So it takes, there are 2 formulas. One is the MDRD, that is modified renal disease.
Right.
Okay. And you have a Cockcroft-Gault formula.
Mhm.
Okay. These both formulas are suitable for adult population.
Mhm.
Okay. We have to take the age of the patient.
Mhm.
Okay. And the creatinine value.
Mhm.
Okay, these are for MDRD formula. We get an EGFR, and MDRD is generally the more widely accepted formula. And we have a Cockcroft-Gault formula in which we add the weight of the patient. So the formula takes all these 3 into consideration, and then based on the EGFR value, okay, the patient is classified as having a renal
Chronic renal
failure,
disease.
chronic renal disease. Now, 60 to 90 is taken as stage 5 and is not really considered as a renal failure,
Right.
though it is there on the report. Anything less than 60 is to be taken
Yes.
as a impending renal failure, and then
Right.
nephrologist has to take care.
Sir, this EGFR is reliable or spot microalbumin?
Yeah. So EGFR, it gives you the filtration capacity of the kidney. Okay, whereas microalbumin is useful for an identification of early damage to the kidney. Your EGFR may be normal, but your microalbumin may be elevated. Microalbumin is that in early damage, the protein, the albumin, which should not be leaking through the kidneys, starts leaking at a very small microscopic, not even microscopic level, at a microgram level. Okay, which cannot be detected in your urine routine. Okay, so in hypertensives and diabetics, if you want to identify that if there is an early renal damage, you have to do a microalbumin. Okay, there are 2 ways. Either you can do it from a spot sample, or you can do it from a 24-hour sample. 24-hour sample is preferred. Okay, but it is very inconvenient to collect urine in a can.
Yeah.
So we do a spot sample wherein the microalbumin and the creatinine ratio is estimated, and it is more or less proportional to what you get in a 24-hour sample. Okay, so spot sample is sufficient.
So
But the utilities are different of EGFR and microalbumin. Microalbumin is for early damage. EGFR is for classification of the renal stage failure. So EGFR comes late.
Okay, so if early diagnosis, this spot is better.
Microalbumin, yes.
I have two doubts. When we
हाँ.
do this 12 hours fasting of a KN,
हाँ.
समझो there were two set of patients, one who are on thyronorm. So better to take it after thyronorm, you do blood test, or fasting se to khali you do blood test and then you do thyronorm.
So
Take
thyronorm intake does not really matter on that particular day.
नहीं.
Okay, it does not immediately work. So it is not immediately going to alter the results.
हाँ.
Okay.
To assess whether after say the first time when somebody is on thyronorm, now antithyroid therapy, whether it is working or not working, that also judgment अलग थी आपसे क्या?
So NO judgment TSH level thi also. It is for monitoring of your thyroid disorders. TSH is the only test which has to be followed. Okay. And we generally don't ask for a fasting for a TSH test. It can be done at any time. Yeah.
And same for the cholesterol lipid profile. If that 12 hours is not done, say 10 hours, तो खाली triglyceride affect असे क्या बंदा करेगा?
No. So fasting is only for triglycerides. Okay. Your cholesterol, HDL, LDL are independent of your fasting status.
Yes.
Okay. Now you said 10 hours. Now for general, the guidelines say 10 to 12 hours. Okay. So 10 hours is sufficient. It is actually not even 10, 9 to 12 hours. 9 hours of fasting is also sufficient. However, in some cases we do see that the triglyceride elevations are there. Okay. In spite of fasting for 9 hours. For them, if the triglyceride levels are too high, okay, we may call them again with an extended fasting. Okay, so that will be either 12 or 14 hours, okay, depending on the patient's convenience. More the better. That is the concept, okay, when we do the test. Now, there is also a concept of a non-fasting lipid profile. When you don't fast at all, kabhi bhi karo. Okay, and that concept unfortunately is not caught up in India because of traditional beliefs, but that is actually good because when we are doing a lipid profile, okay, we want to find out if the triglycerides are actually high or not. If you give it a prolonged fasting, the triglycerides are going to come down. Why? We want to catch the high triglycerides, right? So then, non-fasting lipid profile is a better concept. Isn't it? That you have, so in non-fasting lipid profile, if you have a triglyceride level more than 400, okay, after that you have to do a fasting triglyceride. If you have a triglyceride less than 400, you don't have to do a fasting lipid profile. You can just carry on with your regular lipid profile.
Anything else? Anybody?
One last, sir.
Yeah,
sure,
So a
sure.
lot of patients बोलते ना homeopathic medicine is steroid है. So are there any tests, to give them?
मुझे भी पूछते हैं.
हमारे मुझे भी छाप देंगे हम लोग.
So
Tested by Jariwala.
I think there is a drug testing laboratory somewhere opposite Cooper Hospital, if I'm not mistaken, who tests for what is there in the medicine. Okay. It is not in our area of expertise to do that test, but then there are other labs which are available. They might be able to.
That comes under forensics.
You have to do by immunofluorescence.
That's
Remaining.
But any more?
पहले तो आज है ना
एक टाइम्स ऑफ इंडिया में आपको आर्टिकल है वो.
Yeah, we have the copy. Do we have any more questions, interactions?
Yes.
Yeah.
Two more.
Okay.
T3, T4 versus free T3, free T4.
Yes.
Which one is better?
So see, generally what is preferred is free T3, free T4 because.
But then, is there any difference?
I'll tell you. So FT3, FT4 is the molecule which is active. Okay. And in circulation, these are the T3 and T4, the total T3 and T4, they are bound to albumin. Okay, whereas free T3 and T4 are biologically active molecules. So T3, T4 levels, because they are bound to albumin, they are dependent on the protein levels. Any fluctuation in the protein or the albumin level, T3, T4 level will also fluctuate. So to eliminate that, okay, FT3, FT4 are done.
And difference in the cost? Is there any of the same?
Really, I think 50, 100 rupees maybe. Not much.
LDL versus LDLC.
It is the same. It is the same. LDL-C is LDL cholesterol. LDL, the same thing.
But then there are certain cardiologists who specifically ask if the triglyceride levels are very high, they specifically ask for
Okay.
LDL-C.
So that what you are saying is LDL direct. So there are two ways to measure cholesterol, LDL cholesterol. One is you have the Friedewald's formula, okay, wherein total cholesterol minus HDL minus triglyceride divided by 5. Okay, that gives you the LDL
But
value.
that works only when
That
it
works
is less
when
than
your
400, right?
that works when the value is triglyceride value is less than 400.
400.
If the triglyceride value is more than 400, a direct LDL has to be done. Now it is not mandatory to do LDL for all cases. Okay, in our lab what we follow is we follow a cutoff of 250. If the TG is more than 250, we do a direct LDL. There are labs who stick to the Friedewald's equation, they will do it at 400, and there are labs who will do only direct LDL, they will not do the calculation at all. So it is the lab's choice what to do.
So allergy test usually which we do immunology of IG. So एक આવે છે CRD method ને અને બાકી હોય છે ELISA.
So it's a
Which is more specific and what should we analyze?
So see, there are 3 or 4 types of allergy tests. Okay, આપણે IG હમણાં બાજુ પર મૂકી દઈએ, that is the screening test. The ELISA panel what you talking about, એમાં કેવું હોય કે sorry मैं बीच में गुजराती बोलना चालू हूँ. So there are say for example if you are testing for 200 allergens. So in ELISA methodology what happens is that there may be 10 wells or there may be 20 wells, and in each well there will be 10 allergens. Okay, so you put the sample, you process the test, 3 hours if you get a reaction, okay, if there is a reaction in say well number 1, then well number 1 will be further extrapolated to the 10 allergens which are there in that test. But if it is negative, okay, all 10 will be reported as negative. Now the problem here is that because there is a cocktail of allergens, the sensitivity goes down. Because you're not doing one test at a time, you're doing 10 tests in a single well. That is the problem with ELISA. Okay, and these tests are very cheaper. I think 2,500, 3,000 mein you get good 200, 300 allergens. But this is the challenge, wherein the sensitivity is extremely poor. Then what you have is the line assays, wherein you get the panels. Okay, so line assays are similar to ELISA. Each panel will have maybe 18, 20, and some panels we use, they have 40 allergens, and they will be specifically identifying which allergen is positive. So they will be tested for those 40 allergens or 20 allergens which are there. Okay, so there are individual tests in a single panel. And then when you go to CRD panel, the CRD panel means CRD means component resolved diagnostics. That is the highest allergy test available across the world, and it goes for testing to the protein level. Now in allergy, if you eat something, okay, there are hundreds of proteins in any fruit or any food stuff. Okay, the CRD panel will identify the specific protein against which that person is allergic to, and with the identification of that protein, the person can be subjected to customized immunotherapy to get them relief from the symptoms. So that is the advantage of CRD panel. CRD panel will test for 265 allergens, 265 proteins. Okay, so it is not that they will tell you, okay, for example potato है, potato में 1, 2, 3, 4 प्रोटीन टेस्ट हुआ है, उसमें से ये वाला प्रोटीन पॉजिटिव है. Okay, so there are instances wherein we have identified a protein which is present only in apple skin. Okay, and pulp is negative. तो उसको लोग कुछ मत कर, तू छिलका ले बराबर है. Try go for immunotherapy, it will cost you lakhs. Okay, just told him simple, just remove the skin and try. It worked for him.
A lot of time people have this chane ka atta. So that protein is very common. A lot of people with this have at least either egg or something or chana.
So besan is what you're saying. Okay, so besan protein, I'll have to check it is available in that protein. I'm myself allergic to besan. If I apply on my skin. My mother used to do a lot in the childhood face. So I used to become red. So I can consume, but I cannot tolerate it on my skin. Okay, so I'll have to check if that particular protein is there or not. Okay, but eggs, yes, eggs are included in that particular panel.
So we have seen चना का दाल खाएगा तो कुछ नहीं होएगा, लेकिन चना खाएगा तो
Oh, sorry, maybe some
We have to order
modifications
like
happening.
allergic by CRD.
Sorry?
CRD is more sensitive.
CRD is the best available test, but yes, the paste
It's
it
expensive.
should be affordable. It's pretty expensive. So I have one more slide left.
Yeah, please.
So this is done. So this is again. I just want to bring to your attention that now, like platelets, there are a lot of reticulocyte parameters are also available. Okay, we have the CHR, the reticulocyte hemoglobin content. So these parameters are all useful again for monitoring of therapy. Many a times what happens is that we do not see a very drastic increase in the reticulocyte count. Okay, so earlier it may be 2, it can go to 2.5, but then we don't see a very drastic increase in the retic count. But with this particular parameter, okay, you can see the amount of hemoglobinization taking place in the reticulocyte. Okay, so once you have a higher hemoglobinization compared to the previous result, okay, you know that the therapy is working. Okay, same way there is an immature reticulocyte fraction wherein the same principle, immature reticulocytes are released from the bone marrow. Your reticulocyte count may still be normal, but those presence of increased immature reticulocytes will tell you that the treatment is working. Okay. Same way there is one more calculation called the reticulocyte production index, okay, which if high, okay, it is seen in hemolytic anemias, because in hemolytic anemias there is a profound reticulocytosis. So if it is high, it is seen in hemolytic anemias, and if it is less than 2, okay, then it will be seen in your marrow suppressive conditions like non-response to therapy, aplastic anemia, okay, or other myeloid illnesses leading to suppression of erythroid series, something like that. So just because we were discussing today, I just thought I'll bring them out. Okay, again, not very well utilized, but these are available. There is not much awareness regarding this. So, okay, thank you so much.
Thank you so much.
We have the Dr. Vijay. One for your clinic.
Thank you.
Yes, ma'am.
Thank you.
This is for your home.
Oh, thank you so much.
And yes, sir, please.
So this is my wife, no?
Yeah.
Thank you.
Thank you very much for sparing time. You have a tight
My
schedule.
pleasure, sir. My pleasure. And again, apologies for being late.
एक हमारी तरफ से
नहीं